Kai is a 7-month-old boy who was rushed to the emergency department by his parents, having noticed blood and mucus in his stool. In the past 24 hours, he had been having recurrent episodes of colicky abdominal pain. During these episodes of pain, which last for about 1 to 2 minutes, he cries inconsolably and draws his knees up to his chest. Between episodes, lasting around 20 minutes, he appears comfortable and behaves normally. He has also become progressively lethargic. His parents also report that he recently recovered from a viral illness with cough and cold symptoms. An abdominal examination reveals a distended, tender abdomen and a right-sided, sausage-shaped abdominal mass. An urgent abdominal ultrasound scan confirms a diagnosis of intussusception. Intussusception is a condition in which a segment of the intestine folds into the segment next to it, similar to pushing the end of a sock into itself. It is the commonest cause of intestinal obstruction in infants between 6 and 36 months of age, with the peak incidence occurring between 5 and 9 months, and boys are affected approximately twice as often as girls. The cause of intussusception depends on the age of the child. In infants, most cases are idiopathic, meaning no definite cause is identified. However, many occur following viral infections, particularly adenovirus. These infections can cause enlargement of lymphoid tissue aggregates within the terminal ileum, called Peyer's patches. The enlarged lymphoid tissue is thought to act as the trigger that allows the bowel to fold into itself. In older children, an abnormality in the bowel is often the cause. These are known as pathological lead points, and common examples include a Meckel's diverticulum, intestinal polyps, duplication cysts, lymphoma, or Henoch-Schönlein purpura. These abnormalities act as a focal point around which the bowel folds. Let's look at the pathophysiology. The segment of bowel that folds inward is called the intussusceptum, while the receiving distal bowel is known as the intussuscipiens. Now, as the proximal bowel folds into the distal bowel, it drags its mesentery, containing its blood supply, along with it, resulting in obstruction of blood flow and eventually bowel ischemia. This results in mucosal sloughing and bleeding, leading to blood and mucus in the stool, characteristically described as red currant jelly stool. With continued delay, bowel perforation, peritonitis, and sepsis can occur. There are different types of intussusception, depending on which bowel segments are involved. The commonest type is ileocolic intussusception, where the terminal ileum telescopes through the ileocecal valve into the cecum. Other types include ileo-ileal, jejuno-ileal, and the less common colocolic intussusception. The clinical presentation of intussusception is often characteristic. The hallmark symptom is intermittent colicky abdominal pain, which in an infant usually manifests as sudden episodes of intense crying and drawing up of the legs, separated by pain-free intervals, during which the child appears completely well. Other symptoms include vomiting, which is initially yellowish, then later becomes green or bilious, passage of mucus and blood in stool, classically described as red currant jelly stool, as I mentioned earlier, and progressive lethargy. Abdominal examination often reveals a sausage-shaped mass in the right upper abdomen, as we saw with Kai. For diagnosis of intussusception, an abdominal ultrasound scan is the imaging modality of choice, which should be done urgently. The characteristic ultrasound findings are the target or donut sign on transverse views and the pseudo-kidney sign on longitudinal views. So how is it treated? Following initial resuscitation with intravenous fluids, the first line of definitive treatment is by use of air enema to reduce or push back the folded bowel segment. This is usually successful in about 80 to 90% of cases. Where this fails, or in children who are clinically unstable, surgical reduction is done. This involves open surgery or laparoscopy, where the surgeon gently performs a manual milking back or reduction of the intussusceptum. Now here's a very useful memory aid. Intussusception has several food-related associations, from history to treatment. Red currant jelly stool in the history, sausage-shaped abdominal mass on examination, donut or target sign on ultrasound, and manual milking back of the bowel during surgery. Thanks for watching.